I was treating the multitude of male patients. Sometimes across the board, there's a fear of treating a patient that comes in with testicular pain or penile pain, understandably so, because you're like, I don't have the training for that, or I don't want to go into assessing that body part. But, that ultimately is a body part that's just the same as an ankle or a knee that needs to be addressed. It can be debilitating if you have testicular pain. It is horrible. Men don't know where to go. We as physical therapists have a huge opportunity here to treat that.
Today's episode focuses on techniques the orthopedic physical therapist can implement considering the influence of the pelvic floor in their patient management. This episode includes discussion of intimate topics using medically correct terminology to describe organs, genitalia, and their function. We hope you enjoy the discussion and hope it positively impacts your patient care. Welcome to APTA Orthopaedic Podcasts, where we help you stay ahead in orthopedic physical therapy. I'm your host, Luciano Garcia, and today I'll be talking with Kelli Wilson on pelvic floor treatment pearls for the orthopedic clinician. Don't forget to subscribe for future episodes. Let's get started. Kelli, you've been paving the way, opening the discussion of pelvic floor and how this should be common knowledge for all orthopedic clinicians. You started the Pelvic Health Special Interest Group for the American Academy of Manual Physical Therapists. You have a strong background in orthopedics. How did all this interest in pelvic floor training and treatments begin?
Well, thank you so much for having me, being a fellow Texan and my former CI a long, many moons ago, probably like 17 or 18 years ago.
Yeah, sounds about right.
I know. It's always exciting when things come full circle. I went to Texas Women's University and I grew up in Houston. I now live in Austin, Texas. I had the opportunity to practice in a clinic in Central Texas in Killeen at Integrity Rehab, which was a clinic that was one of the few in the country at the time, 15 years ago, that only had full-time, one or two full-time pelvic health physical therapists. That was not a thing that long ago. And so I had an opportunity with Janice Mitchell, who owned that clinic, to get training in pelvic health starting out. I was going through my fellowship through the American Academy of Manual Physical Therapists then and getting my orthopedic certified specialty. So I was really building my strong orthopedic background, but at the same time learning about pelvic floor. And I had the opportunity to work with active duty military soldiers. And I was working with not just the female population, but the male population.
That's Fort Hood up there, right? Fort Hood?
Yes, Fort Hood. Yeah. So I was seeing crazy injuries, falling out of a helicopter, a tank injury. And these male patients had nowhere to go. And I was seeing really effective strategies and treatments with my orthopedic background to be able to help them get back to being active duty, to be able to live their lives. And for that reason, I started Alhooie Education, Alhooie Pelvic Health Education, which is an education company I started in 2015, started teaching courses, weekend courses, converging orthopedic concepts with the pelvic floor and showing the efficacy of that for the male and female population. And so it was out of the pure love of wanting to share this knowledge and information because there's not much research out there. We're working hard on doing and getting more and more research, but conservative treatment just is not, it's not, being done as comprehensively as, a musculoskeletal condition for low back pain, let's say, at the sedentary job. So we've got a ways to go. So these are clinically anecdotal concepts. But hopefully today, when we're talking a little bit, I'll be sharing some of the concepts and you'll be surprised. Some simple strategies orthopedically can bring you really far with your patients that are very complex. So that's the gist.
Cannot wait. I've seen you lecture twice now at CSM, with the most recent one being, 2 months ago here in Houston on pelvic floor training. I know that's a very important topic for you. If the APTA orthopedic clinician could incorporate, let's say, just one or two extra subjective questions in their evaluation, and this is with patients with lower back pain, what might those one or two questions be?
I would I would want you as a clinician to consider delving a little bit more beyond just, are you having uncontrollable loss of urinary function? We're
Mhm.
taught in PT school, like if they're having complete loss of urinary function, not being able to hold, or bowel function, what do we're told that's a red flag and they need to get further testing and sent back to their provider. But
Mhm.
there's so much more to that, right? Like, I mean, we need to do better than that. And that's why I really became involved with the American Academy of Manual Physical Therapists, because we're supposed to be the best of the best, get the most high
Mhm.
level training, but we're kind of, scraping over with the concepts of what pelvic floor or what that question should mean. And yes, if they're having full loss of their urinary function and having full accidents and not having any sensation down there, yes, we need to send back for a red flag. But I would consider, how is functionality being impacted for this patient's, like, sexuality. Like, let's say if they have low back pain, they if are they able to, well, this is diving in, but are they able to become rigid, have a full erection if it's a male,
Mhm.
but
Mhm.
they're not able to maintain that or having lack of that due to pain? Like, is their function being impacted because of their pain? And is their pain to their low back? Or is there a positional change while they're having intercourse? And we can dive into how you open up that conversation.
Yeah.
But like as a clinician, correlating that, because sex is function, and correlating,
Mhm.
is it connected with their low back pain, then you can dive into what you need to for your goals and what improvement that patient can be from there.
Mhm.
So
Nice. Yeah. Would you consider not incorporating pelvic floor exercises into a standard lumbar or lower extremity treatment plan viewed as incomplete?
great question, because you're like,
Mhm.
what
Mhm.
training do we need to be having as an entry level physical therapist, and what needs to be included? Because if I say, as a pelvic health therapist, absolutely, I feel like that's incomplete and you're missing the buck here, and being comprehensive with your patient, that's not fair. Because, I mean, as a clinician, we're trying to be comprehensive and include all these different systems and body parts. But to be fair, I think that there is some ways to tackle the pelvic floor without necessarily, you can have basic concepts of the pelvic floor, but understanding how the whole system works with the diaphragm, with breathing, you can easily, I feel like that it's incomplete if you don't have a basic understanding of what's happening with analyzing a patient's breath. How is their intercostal
Mhm.
angle? Is their lower rib expansion happening with their inhalation and
So
exhalation?
true.
Because the understanding the concept that the diaphragm is synonymous with the pelvic floor and they need to be working synergistically is a basic concept. So if there is abnormality happening and occurring with breath, you know that there's going to be abnormality happening with the pelvic floor. So I think that we can layer and add some basic concepts into the initial clinician, and we should be seeing that assessment in every patient that comes into the clinic with low back pain. We should be looking at breath and breath holding patterns and how lower rib movements happening. Yes.
I just, from my perspective, I remember probably about 10 years ago, I started taking some pelvic health courses, and it just opened the door. It just opened, opened my eyes. And I considered it more like a missing link. It was the
Mm-hmm.
missing link. Some of these patients, I was having good outcomes. But once I added just a few simple pelvic floor pearls to my treatment, my effectiveness with these lower back patients improved.
Yes, and there's an actual validated study, a validated assessment tool called the coccygeal movement test, and it's where you're palpating the posterior aspect of the inferior aspect of the sacrum. I have it right here. I have the model right here. Like,
Very
you're
nice.
palpating the inferior aspect of sacrum or and the coccyx meet together, and you have the patient just taking a deep breath in, and you're exhaling out while they're in standing or sitting, and you're feeling for inhalation that coccyx should move into your finger, and on exhalation it should move back into a flex state. And it should be, and it's very subtle, but once
Is
you
that
start practicing as a clinician,
with a
you
deep
do it over.
breath or regular breath?
It's easier when you're doing it with a deep breath at first, but you can get them to do regular breath. As a clinician, you can do this out in the clinic over close. And it can be a game changer as far as just feeling for, is there movement, and playing with the patient's center of gravity over their feet and getting them stacked appropriately, playing with getting their thorax stacked over their pelvic floor. And just by awareness for their standing and sitting posture, they can automatically get better optimal movement that's happening with the pelvic floor. And therefore, like, let's think the lumbar paraspinals aren't overworking. Maybe they're sitting in a hyperlordotic curvature, and with every breath, they're causing tension in their paraspinals. So you get stacked, then they're getting more effective strategies throughout the whole system, working together as a team instead of just one part overworking all the time. So that's you can look that up online. I even have an Instagram reel showing that, under Alhooie Education, how to do that test. Like I said, it's validated. There's an article. We can put the link, we can link it. That's a free access article. So yeah, that's another quick little easy trick.
Nice. From your most recent talk at CSM a couple months ago, it was on testicular pain. What are some take-home pearls from that talk?
It's interesting because treating the male population, when I left my job in Clean, I was treating the multitude of male patients, and I see this sometimes across the board. There's a fear of treating a patient that comes in with testicular pain or penile pain, understandably so, because you're like, I don't have the training for that, or I don't want to go into, be assessing that body part. But, that ultimately is a body part that's just the same as an ankle or a knee that needs to be addressed. And as you probably know, well, maybe you don't know, but as a male, like, it can be debilitating if you have testicular pain. It is horrible. And the problem with this is that men don't know where to go. They're kind of shuttled off to be like given a big dosage for antibiotics, thinking that it's the prostate's fault. And they're not giving an out and a means through conservative treatment for that. So we as physical therapists have a huge opportunity here to treat that. And so what my talk was, what was interesting, me and Adrienne McCauley and I presented, and what we did was we gave assessment and treatment strategies, about 12 or 13, and we never in any of them touched the testicle. Never touched, the scrotum, around any of the genitalia. We only showed how orthopedic assessment and treatments are effective because if you understand the anatomy behind what feeds into the testicle, the nerves, which are coming from the thoracic lumbar region, and then you've got the sacral region to the pudendal nerve. But understanding the anatomy of those nerves and what nerves they are, you can be a big game changer with your patient. And also assessing hip active range of motion and passive range of motion, because those muscles tie in so much with the pelvic floor muscles, especially with the male population. The male pelvis is naturally going to be smaller in its outlet because you guys don't need to have babies, right? Nope. But I think the problem is that there's a natural proclivity to have stiffness there or less mobility than females. That's why you guys aren't as susceptible to hypermobility or SI joint dysfunctions because of that. However, my theory is that because there's less movement in the pelvis or in that musculature and the inferior aspect, when there's even less for some reason after an injury or repetitive positional changes, then that overflow can be really problematic, right? And the pelvic floor muscles overlay with the deep hip external rotators. So when you guys are doing a simple hip lateral distraction mobilization, you can be indirectly like having effect with the pelvic floor muscles and getting some blood flow to that area and getting movement and motility and blood flow to allow for less tension that might be occurring in that area for whatever reason.
Does a clinician have to be pelvic health certified to perform some of these techniques?
If we're talking about doing internal examination, you do need, there's no requirement, but I recommend that you need to go get training and through a course. The APTA has some great courses. Herman Wallace has some great courses. There's other companies coming up. Alhooie Education has a one-day training for vaginal and rectal training internally. I urge a clinician to never be doing internal work if they have not gotten the appropriate training, but there is no specific certification for that, to be clear. But that would be like if someone were to sue you and wanted to know what training you had received and you didn't get any training, then that would be a disadvantage, litigiously for you and very problematic.
No doubt. Do you think just staying externally will get you pretty good treatment outcomes?
So yes, in certain respect, right? I mean, you always have to be at some point maybe with the patient, and you need to get to that internal. You need that internal assessment and treatment. But what you saw a few years ago at the orthopedic section at CSM, I presented with Nick Rainey and Pat Nelson, and we presented on, and we ended up getting this published as a case series. So we took 4, we got it published in the Journal of Women's and Pelvic Health Physical Therapy. We'll link this in the podcast.
Let's do it.
But what we did was we took patients that came with involved and complex pelvic health diagnoses, and for whatever reason, they could not get internal treatment, whether the pain was too elevated, they had hemorrhoids, or whatever the case would be. And what we did was we could only do external treatment and orthopedic treatment, and how they ended up resulting in resolution of their symptoms through those means. Nice. And so you can be thoroughly comprehensive and effective with external strategies, and having comfortability as an orthopedic therapist can really empower you in the clinic, and to not be fearful to be doing those treatments, because yes, you can be safe. I think as long as you're clear in your communication with your patients on why you're doing that.
For sure.
What did I show you with the coccygeal movement test, right? You are palpating along the backside of the coccyx, but you should be palpating the posterior aspect of the coccyx anyways with the patient that's coming in for low back pain. Why do I say that? Because you might be like, why would I do that as an orthopedic clinician? But Luciano, you might remember, like, anyone that has, this is just a side note, anyone that has coccyx pain, that injury usually happened like 20 years ago, and they never remember that they even have pain there until like something comes up. Like if you forgot to assess that or ask that or check that, they're like, oh, I haven't been able to sit on a hard seat for 25 years. And you're like, well, you never mentioned that, like, as the being, they don't even correlate it with their back pain. You agree?
I totally agree. Well, earlier you mentioned students. How much of this stuff do you feel should be taught in their DPT programs?
And great question. In their DPT program, looking at intercostal angle, looking at breath, looking at standing posture, looking at abdominal wall, and getting a little bit more comprehensive an assessment of what the abdominal, because it's not complex, but it's understanding like how the fascia feels, and a basic concept of understanding the organs, right? If constipation can be very impactful for low back pain as well, I think that should be included in entry-level education. You can include external palpation of the pelvic floor on basic just concepts of what a Kegel is, what contracting the pelvic floor muscles are, and what relaxation is, and how the pelvic floor muscles are coordinated without doing anything internal. That could be outside the clothes. And that could be like just a 1 to 2 hour lecture, over those concepts. And I think that could be pretty powerful for the entry level. I think that, going into internal concepts would be something post grad. And if someone wants to go into that skill set and taking some really involved coursework for that.
For sure. Well, that leads to my next question. What are some go-to resources for a clinician that wants to learn more? We've piqued their interest. They want to learn more. Where can we send them?
Okay. Well, I mean, there's a lot of resources. I mean, there's a lot of companies now and
Mm-hmm.
resources. To plug me, I have Alhooie Education. I have an online course for male and female entry level pelvic floor, and I pull all the orthopedic concepts in. I need
Mm-hmm.
to be evolving an orthopedic based class too. That's my goal this year. But APTA, of course, has some the section of pelvic health courses for if you're wanting to be involved heavily in the pelvic floor, and Herman Wallace, of course.
Mm-hmm.
MyPFM has some great online resources, online courses for a minimal monthly membership fee. Global
Okay.
Pelvic Health Alliance, which Tracy Shear has some great curriculum and courses as well. So you have some more tools in your toolbox and fingertips. So I my courses, I have a ton of videos that show external treatment strategies and assessment strategies. I try to be really clinically applicable because that's what I am. I'm a clinician
Mm-hmm.
and not a researcher. And so when I go to a class, I want to know what the meat of it is and how I'm going to apply this clinically. So, and all of
Mm-hmm.
these resources do that as well. Yep.
That is great. Any final words, Kelli? Any final words for the orthopedic clinician audience to be aware of or recognize with this patient population?
Well, I say all sexes can be doing this. Excited for where this is going, and I'm excited to see so much passion and interest from the orthopedic physical therapists. Like going to the conferences have changed in the last
Mm-hmm.
7 years.
Mm-hmm.
From having just a speckle of clinicians from the orthopedic side now really wanting to learn more and really seeing that missing piece. So we're getting more information out there. There's more things on Instagram, Facebook. I mean, there's more resources out there. And you can always reach out to me too. I'm going to have my email address,
Mm-hmm.
my contact information if you are interested in mentorship opportunities or ready to even discuss complex cases. I'm excited to see where we're going, and I'm excited for the patient population because they really, really need this across the world. We need more clinicians looking at this aspect because it's needed.
For sure. I want to thank you, Kelli, and thank you for tuning in to APTA Orthopedic Podcasts. We hope you found today's episode informative. Remember to subscribe, and until next time, stay ahead in orthopedic physical therapy.
Thank you.